Okay, and now let's talk about sleep apnea syndrome. So, sleep apnea syndrome. And what you should remember, we got three types, but mainly those are two types, and one is mixed. So, first of all, first one is obstructive sleep apnea. Obstructive sleep apnea. That's called OSA. Then we got central sleep apnea. And then we have a mixed one. So it's combination of both. And remember only that obstructive is the most common. It's like 84%. You see this most commonly. And you get a pretty nice treatment for that. Well, this one is very rare, like 1% only. And the mix is like, so combination of both is like 15%. Okay. So, but we will talk about the obstructive sleep apnea and central sleep apnea and the differences. Okay. So, well, what's the cause of obstructive sleep apnea? Well, the main point, and I'm going to draw it over here. So let's draw this. This is a face, but cut it in the middle. So you see like nose over here. This is a nose. This would be the maxilla over here. Okay. And this is a soft palate here. These are the upper airways, so this is pharynx, okay, like that. Over here you have a tongue. Here's the tongue inside the mouth, okay. And let's do the bone like yellow. We got teeth over here. This is going to be mandibula, so the lower jaw. Okay. So let's make the bone and teeth again over here. And here we have the hair. Let's do the hair. Okay. So like that. And you know, we can put, if you want, eyebrows here and an eye. Okay. So, but let's make a better nose. Fine, but it doesn't matter. What matters, it really matters, is the space over here. So over here you got a soft palate. This is a, let's put it in green. This is soft palate. And here's the tongue. This is the tongue. And the green thing over here, this you call the retroglossal space. And that's very important. So we're talking about pharynx, and we're talking about the soft palate and the tongue. And what happens is when you lay like this on back, typically, that like in normal healthy sleeping, this should be still, here should be, I'm going to put it in red or blue. Here should still be a space for breathing. But typically in older patients, but this can sometimes really happen in children, but also in, but typically in adults, mainly men, but also women sometimes, and it runs in the families. What happens is you lose a tone of these upper airways, and that's why this gets blocked during the night. And so over here, especially when you lay on the back, this blocks. and you got a apneic pause, which lasts like seconds, only seconds, rarely minutes, but mostly seconds. And I mean, if it happens once in a night, it doesn't matter, that's fine. But if it happens 30 times, 40 times, 50 times during an hour of your sleep, this is serious because you're not sleeping enough. You always wake up to a certain point, and although you won't wake up fully, the sleep is not efficient. You are tired, very tired during the day, and this is a risk for many other things. I'm gonna mention some, but the problem is loss of tone in the airway. Sometimes this worsens. I mean, of course, if you have some allergies, or also you have enlarged tonsils, for example. Okay, so the obstructive sleep apnea is about blockage and narrowed airways, and it's about the soft palate and uvula over here and everything that blocks it. Okay. Well, and what are the consequences? So if you have these apneic pauses, many for 1 hour, this leads to many things. And of course, this increases stress, sympathetic tone, and you got hypertension and all kinds of other things. And in a way, over here, you can think of it, it's a temporary hypoxia with hypercapnia. Okay, when you stop breathing, the CO2 goes up, oxygen goes down. And what's crucial over here, also, you should understand that the hypoxia decreases not in some parts of lungs, but in all lungs. And you remember the reflex that we have. We have the hypoxic pulmonary vasoconstriction. So, and this works normally physiologically. This reflex is made to make the ventilation and perfusion match. So basically this controls locally the perfusion of the lungs, and the parts that are well ventilated should be well perfused. But in this case, you get hypoxia everywhere. So there's massive vasoconstriction everywhere just for a short period of time. So during these apneic pauses, you have increased pressure in the pulmonary artery because of the resistance. It's an increased load for the right heart, and you end up after many years with pulmonary hypertension. At least 50% of people end up with pulmonary hypertension. And this is one of the important mechanisms. But also, what you should understand is when there's a blockage during this apnea and the lungs expand, although there's no air coming in, you decrease the pressure in the thoracic cavity. So you got a negative intrathoracic pressure, okay? Plus, I'll draw it in a different, negative intrathoracic pressure. And what happens is you got a increased, in this case, when there is a decreased pressure, there's an increased venous return to the right heart. So there's increased preload of the right heart. Okay, so increases the preload. The heart then ejects against the increased resistance because you have a pulmonary hypertension at that moment, or there's vasoconstriction. And what happens also when there is an increased venous return during diastole, actually, if I will draw the heart over here, this is left ventricle, right? Then the heart gets filled more, and there is a, let's say, displacement of the interventricular septum to the left during the diastole. So just that you understand how many problems, and I just mentioned two, and there are many other, but this happens during the apneic pauses. And if this happens many times per hour during one night, and then 365 nights per year, and then it multiplies by years, obviously you end up with a serious situation. And the consequences then, and there's a continuous hypoxia, so this can lead to, there's decreased delivery of oxygen to the heart, so you can have MI, you can have a stroke, and increases risk of many other serious diseases. So obstructive sleep apnea, very serious disease. And cool thing about obstructive sleep apnea is that nowadays you got many machines that can help you with that. Of course, you can have also surgeries, but for example, you can have a ENT surgery where they cut the uvula, etc. I don't think this is too efficient. You have efficient surgery, especially in people who have small maxillas. You can have, also a very serious cosmetic improve when they have too small maxilla. You can move the maxilla in front, and that's how you're gonna mechanically open the airways and keep them open all the time. So it's a maxillofacial surgery, but the elegant solution for this nowadays, and it's very popular, and more, especially men have it, but also women and some children as well, when it runs in the families, is a CPAP machine. And CPAP means continuous positive airway pressure. And this machine, which you have next to your bed, and you put a mask, nasal CPAP mask. What this does is monitors the pressure in your airways, and it increases slightly the pressure of the airway. So the incoming air has a bit higher pressure, and this keeps the airways open. So the retroglossal space won't close, and that's why you don't have these apneic pauses. So it really helps the people. Then they sleep, they have a much better quality sleep. They're not tired during the day, and the risk of pulmonary hypertension, for example, seriously decreases. Okay, so remember CPAP machine. So that's obstructive sleep apnea. But then we have central sleep apnea, and this is a different problem. Over here, and typically over here, the problem is in the respiratory centers and sensors of O2 and CO2. So, and there's sort of a imbalance of these central and peripheral chemoreceptors, imbalance of central and peripheral chemoreceptors. So there's, for example, a delay in sensing the levels of O2 and CO2 by the central and peripheral chemoreceptor, and that's why the ventilation, it's not tuned properly. But there are many like central problems also. This is one of the examples. But the outcome is what you see sort of is the Cheyne-Stokes breathing pattern or respiration. So first you breathe fast, and then you stop, and this is the pause, and then again you breathe fast, and then you stop. The problem is in the control centers. There's no obstruction if we talk about the pure central sleep apnea, but we got the mixed ones as well. Okay, but this is also very serious, but unfortunately it's not so easy to treat because the problem is elsewhere. It's not the obstruction. So what you can do first, it depends. If this pattern, the Cheyne-Stokes pattern, is due to, or these apneas are due to, let's say, failing heart, you treat the failing heart. You're trying to address the medical problem itself, okay? Or it could be due to opioids, so you decrease the opioid medication if there's some depression of the centers. Or you can also use CPAP, but it's not so efficient. Better is adaptive servo ventilation, ASV. That means that this machine like controls your breathing or checks your breathing in case there is a pause, it breathes for you a bit. Okay, or also you got the bilevel positive airway pressure. It's a different mode of ASV where it changes the pressure during inspiration and during expiration. So it's very sophisticated. Also, you can give oxygen. Okay, you help them with oxygen if there is this central sleep apnea. So there are many ways, but over here there are many causes. It's not as simple as an obstruction. So you have to find the cause, and it's very hard to solve actually. And someone could ask you, how can you tell these two apart? So how can you tell the obstructive sleep apnea and central sleep apnea apart? And what's the difference? Well, of course, the people, they go to a sleep lab and they get a polysomnograph over there, which is a machine that monitors movement of the chest, the flow of the air from the nose, EEG, etc. Sometimes they get the machine out, the newer machines, they can get it home, okay? So it's sort of a partial polysomnography. But to tell these two apart, it's very simple. You don't need EEG. You just need to monitor the movement of the chest and the flow of the air from the nose. And in case the person has no flow of the air, there he has a pulse, but the chest is moving, obviously it's the obstructive sleep apnea. If the movement of the chest stops and the flow of the air stops, that's the central sleep apnea. So this is a very simple way how you can tell. Most commonly, it's the obstructive sleep apnea. Again, so you should imagine older men, typically more common than women, typically overweight, but not necessarily. The main point is the loss of tone during the sleep. And one of the hallmarks is, of course, snoring. But again, there could be people which are snoring and don't have apneic pauses, so they're fine. So you aim for the ones which have apneic pauses. And still, maybe to remind you, because over here we talked about the local regulation. So in lungs, remember again, it's the lungs. This is different than in the other parts of the body. That's the hypoxic pulmonary vasoconstriction. Okay, hypoxic. So that's the let's say perfusion regulation in lungs. That's special. Typically, when there is hypoxia in the alveoli, decreased partial barrier oxygen, there's pulmonary vasoconstriction. Pulmonary vasoconstriction. In contrast to this, let's give you other examples. So remember, for example, how is it with skin? Well, skin is very much regulated by sympathetic trunk. So when sympathetic trunk is activated, there's vasoconstriction. But watch out, very important local regulation is thermoregulation. Remember, in case you are cold, there's going to be vasoconstriction. If you're warm, there's going to be vasodilation. Okay. So, and if we talk about the regulation of the perfusion of the heart, so I mean coronaries, it's the local metabolic factors that are important. So decreased O2, increased CO2, pH decreased, okay, potassium increased. So all of these cause vasodilation of the proper part of the myocardium. So local metabolic factors. That's very much. But majorly remember decreased O2. That's like typical. It's the same with striated muscles. With striated muscles, there's light vasoconstriction in the muscles through sympathetic trunk. But when you start to use the muscle, you're going to start to run, there's a massive control of the metabolites again. So again, over there, there's a massive local regulation that is dependent on the catabolites again. So catabolites. So decreased pH, but also if the partial pressure of O2 decreases in the muscle, they will increase the perfusion of the place. Okay. And now very important, brain. Remember, brain is again very much dependent on the autoregulation, local autoregulation. So what parts of the brain are working and are consuming the nutrients and are producing catabolites, this place is going to be more perfused. Okay, so it's very dependent on the metabolism again. Local control, metabolic control. Okay, and remember that it has a pretty strong pressure regulation, and the brain tries to keep the pressure somewhere between 60 and 180 millimeters of mercury. Okay, but what's the difference comparing the other tissues like heart and striated muscle? The most important trigger in brain in increasing perfusion, thus vasodilation, are increased levels of CO2. So remember, brain is special, and more important are the increased levels of CO2 for vasodilation, triggering vasodilation, than, let's say, decreased levels of O2. So this works much better than the decreased levels of PO2. Okay, so crucial is CO2. Okay, and when we can use this, it used to be used all the time in traumatic brain injury. Now there are debates if it's worth it or not. The outcome is that still it's okay to use and it helps, but there are more regulations to it. It's not like if someone comes with a brain injury and brain edema, you're gonna hyperventilate the patient. But basically that's the result. So remember, if you have traumatic brain injury, and it seems like you're having a brain edema that increases on a CT or whatever, so the intracranial pressure increases. That should be like below 20 normally millimeters. So the intracranial, so the thing you can try, but very temporarily, like 15-30 minutes, and typically not the first day, rather the second day after the brain trauma, when you know it looks, now it's a more serious selection to hyperventilate the patient, not like arbitrary, but I mean, when you see that the intracranial pressure goes up, you can hyperventilate the patient for 15 to 30 minutes. And your goal is to have hypocapnia, so partial pressure of arterial CO2 somewhere between 30 and 35 millimeters of mercury. And what this does is it causes vasoconstriction. So it decreases the amount of fluid getting into the brain, and sort of the idea is this will decrease or sort of blunts the edema, growing edema, okay? But of course, you see vasoconstriction over here, so there's a risk of ischemia, etc. Okay, so it's not so simple, but anyways, remember, typically, if there is a brain injury and it seems like that the ICP goes up, this is what they do typically. They hyperventilate the patient for 15 to 30 minutes. It's effective only this short time, then it's not effective and has many consequences. But the short-term hyperventilation could decrease or blunt the increase of the intracranial pressure. Remember, you got a cerebral perfusion pressure, which is mean arterial pressure minus ICP. And the goal of everyone is to keep the CPP somewhere between 60 and 70 millimeters of mercury. That's in another video. Okay, so, but the main message over here, if we talk about the perfusion regulation, remember lungs react in opposite way to hypoxia. They react with vasoconstriction. Heart and striated muscles and brain, they of course react by vasodilation, and brain especially, watch out, brain mainly the vessels react first of all to increased levels of CO2 for vasodilation, okay? And what you can do if there is a brain edema after the brain injury, yeah, you can hyperventilate the patient for 15 to 30 minutes if you want to temporarily decrease the intracranial pressure. So that's it for now.
So thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.